Dear guests, welcome back to the JoyAge International Symposium 2022. I'm your MC, Dara Learn. Before we start, we'd like to thank our speakers for their generosity in allowing us to record today's session and make the resources online. To our audience, you're more than welcome to share the recordings with your colleagues and fellow researchers, which will be available on our website later. Should you have any ideas or questions for our speakers, please feel free to type and send us through the chat box anytime during the presentation. We'll collect them and address them later in the Q&A session. Today, we'll focus on the interventions for older adults with mental health needs. We are honored to have Professor Ricardo Araya and Dr. Marcia Scazufca from King's College London joining us today. Professor Ricardo Araya is a professor of global mental health at King's College London and the director of the Centre for Global Mental Health. He is an expert in developing and implementing practical, affordable treatments for mental illnesses, especially in places with limited resources. Today, Professor Araya will discuss the effectiveness of a step care program for women with major depression in Chile. Professor Araya, please.
Oh, hello, everybody. Let me share my screen with you. First of all, let me say that I'm very grateful for your invitation to be part of this wonderful conference. And I'm very grateful for you to put as me and Dr. Scazufca after me, sharing with you a couple of experiences, well, more than a couple, but some experiences of treating depression in a very different continent. Both these presentations covered the region of South America that I hope for a lot of you would be of interest. Of course, there are lots of, there is a very large Chinese community in both countries. So anyway, thank you for your invitations. So I was asked to talk about an experience that has taken place almost 25 years ago. But I have to say it is one of the things that I cherish the most in my 35-year career doing research in mental health for a number of reasons, which I will try to explain, but perhaps, for two very important reasons. The first of them is that it was perhaps the first successful depression treatment program in primary care. And when I say successful, I mean following a randomized controlled trial that proved the effectiveness of this intervention. Before this, there had been other people trying out the idea of introducing depression treatment in primary care in other low and middle income countries. But nobody had at that point actually tested and proven that it was cost effective. So this was really the very first time when that happened, and created quite a bit of stir around the world. And subsequently, over many years, I had been able to share this experience with many other colleagues in other parts of the world, and adapted and try, different but similar treatment programs in primary care. So let me tell you a little bit of what we did, but maybe I should start by give you a brief idea of what this country is all about. Chile, where the study took place, is a country in South America. And as you can see, it's a very thin and long country, very long. I put a map of North America so you could have a rough idea how long it is. Yes, people, I don't know why it is called Chile, to be honest, but I couldn't stop thinking that it's got the shape of a chili that you would all be familiar with. Chile is a small country. It's got about 19 million people population right now. It has been growing very rapidly with a very large wave of immigration from different countries, but mostly neighboring countries that have come to Chile. Almost 2 million people have come to the country over the last 5 years. Most of the population live in urban locations. I would say probably about 85%. So a large part of the country remains unoccupied. The country, when we did the study, was considered to be a middle-income country. Ever since then, there was growth on macroeconomic indicators that allow the country to be classified by the World Bank as a high-income country with a $15,000 income per capita. Levels of literacy are very high, and that to some extent may prove that. Let me just get rid of the bar. So level of literacy are very high, so that's something that you need to consider when you hear about the results. So the whole thing started with, at least my journey on this, like the journey of many new young people, trying to understand what the problem really was, and if there was a need to do something. So we started with the usual thing. We did very large household surveys. We did the largest household survey of the capital, Santiago, that has approximately 50% of the total population. And we discovered that the prevalence of depression was very high, and especially among the poor and women. So that was no surprise, as we had seen something similar happening in other places. Okay. One of the things that we discovered with these surveys, it was that the very few of these people with depression had ever reported receiving any kind of professional help. And this was a lot clearer among poorer people who at the time we said they were hit by a double burden, the burden of untreated depression and poverty. Just to show you a little bit of what the inequalities were, this is a few years after we did the trial, but it represents a little bit of what it was happening in the country. But what you can see in here is that the prevalence, which is on the blue bars, was a lot higher among those people who were receiving state insurance, in other words, the poorer segment of the population. And as you can see on the red bar, those people that represent the people who had access to treatment, the sector that had the highest prevalence, it was the sector that had less access to medical consultations. And on the left-hand side, you can see the people who had private health insurance and therefore probably more likely to be more affluent. Those people had lower prevalence, but had access to much higher access to medical consultation. So this is a good illustration of the massive inequalities that, to begin with, I must say that there was a treatment gap for all people, whatever your socioeconomic status, your chances to get treatment were very low. But if you look at inequalities across socioeconomic groups, they were very visible indeed. So this gave us quite a bit of ammunition, and at that time, we started with a campaign to try to disseminate what we thought it was happening and alert the authorities that something needed to be done. I mean, you probably cannot see the date. This is the front page of quite a popular journal at the time. That this is 1998, I think. We were kind of sort of hammering the message that there was a big problem that needed to be taken care of. But of course, the authorities, and some of you may be familiar with this story, they said, yes, we do realize we have a big problem with depression, but we have lots of problems. So, we may not be able to help with this. And, the first part of the argument was always, not anymore, but, it was that depression and poverty are inseparable companions, or in other words, they are the same thing. So if you want us to do something, that should be alleviating poverty rather than treating depression, because depression is a social problem. So this was a very powerful argument in which, out of ignorance, I have to say, the authorities were saying, we take your point, but, the problem with poverty is, and the consequence is depression. So anyway, I'll tell you how we managed to persuade them slowly. It was very hard, and the reality that the study to begin with was funded by the National Institute of Mental Health in the US in the end, because we were unable to obtain funding in our country. We had to think very carefully about lots of things, and I want to share with you some of the things that we thought at the time. In the first place, why primary care? If you ask me now to think back about, whether or not it was a good decision, I am much more convinced that I was at the time, because primary care should be the center of most healthcare systems in the world. But at the time, we were very pragmatic and practical, and we thought, well, where are we going to find the people that we want to target? And our target was poor people and women. And most of poor people, the only healthcare that they had access to, it was primary care. So that was the place where we could find poorer people. Same applies to women. The main clients in primary care were women. And that remains the case until now. Primary care, at least in Chile and many other countries, is the point where the place where most women have access to, for a number of reasons, some of which have to do with the limited time for access. So if men are in some places, men are mostly working outside, and therefore they cannot access during working hours any healthcare center. Now, these days things have changed so much from 20 years ago. Women are much more engaged in the workforce. So things are changing very rapidly, but I still think that women are the main clients in primary care in most low and middle income countries. A very important point was that we had done some research and we discovered that women were more willing to talk about depression, to talk about emotional problems, and therefore they were more willing or prepared to at least conceive the idea of getting treatment for their emotional problems. And we also thought at the time that, if we work with women, we would have the added benefit that these women would be looking after a family and maybe could eventually help other members of that family, in particular children. We started thinking about, so what can we do? And there were some ideas that I want to share with you that we thought at the time should somehow help us shape the intervention that in the end we wanted to test. And one of the first things we decided, and that was a very, very quick, because we had lots of meetings with people working in primary care, managers, doctors, nurses, social workers, lots of people, to try to understand, what it was possible to do, what it was feasible. And one of the things that came very strong, and perhaps is something that has helped me all throughout my career designing interventions for other settings, is that people do not like to change. And if you're going to change, try to make that change manageable, as small as possible. So at the time, we came to the conclusion that it was better to try to improve what it was already there, rather than creating a completely new intervention. And I think that is a piece of advice that I have for all of you, always think about, improving what is there rather than, introducing massive changes to the system. Sometimes you have to introduce massive changes to a system, but if at all possible, try to move step by step. Efficiency, of course, was a very important thing, especially when you were thinking about a setting with very limited resources. And there was the idea of step care, which is no other thing that you allocate resources according to needs. So if somebody has, a mild condition and eventually or potentially limited needs, you invest, less resources on that person. But if someone comes with a very severe condition, you may have to inject more resources to help that person sort that problem out. Always choose the simplest and the low cost. That's the rule for all low income countries, and go without saying. Effectiveness, it was important, and it still is. You hear a lot about people talking about evidence-based intervention, but there are so few interventions that can show an evidence-based and can prove they are effective. And still, quite a lot of stuff is being implemented at a large scale without any proof that they are effective. I put in here effective, but as you will see, we were pushed initially. The idea was testing effectiveness, but gradually we move on to the cost effectiveness for a number of reasons. Empowering was always very powerful, and it is in most of the South American countries. And empowering not just patients, to be more self-sufficient, but also, and never forget this, empowering people working in the health sector. There are lots of people working in there at different levels. And it's really important to think about, how can I empower these people? How can I recognize their work? How can I make their effort something more efficient that provides a better return for the entire system. Okay, well, let me just to give you an idea, because resources are really essential in this story. This is more or less the ratio of psychiatrists per 100,000 population in Chile compared to other countries. As you can see, we don't have many psychiatrists, perhaps more than in some other countries, like Nigeria and Guatemala, countries where I have worked, by the way. But still the numbers are low. So the idea that you can provide a service based entirely on specialist psychiatrists in this case, in a country like Chile, it's just not, it's not possible. So you need to begin to think more creatively as to how are you going to provide a service with a very limited input of psychiatrists. So the rule is identify and use all the existing resources. And that led me more than 25 years ago to get really into the idea of task shifting. Now, task shifting is no other thing than just simply moving specific tasks where and when appropriate from more highly qualified health workers, such as psychiatrists, to other staff that probably have shorter training or fewer qualifications. And in that way, you improve the efficiency of available human resources. But it's not just simply improving the efficiency of these resources, but it's also the only possible way of delivering services in many settings. I want to emphasize that these people need to have an appropriate training. They need to be supported and supervised for their new roles. And perhaps I should have put in here, but I didn't. They need to be recognized for their new role. Very often, we transfer tasks to other members of the team, but there is no really a recognition of the increased burden that they have to take on as a result of these changes. So what is it exactly what we did? So this is the study. It's treating depression in primary care among low-income women in Santiago, Chile, and it was funded by the US National Institute of Mental Health and published in 2003 by Lancet. So the study was essentially that we identify poor women with major depression. And in order to do that, we had a double screening. So we were screening women coming to see doctors for whatever reasons for the first time. And if they had a GHQ-12, but that you are familiar with it in Hong Kong because it's being used there. And if it was over a certain threshold, more than 4 in this particular case, we would invite those people to come back in 2 weeks' time for a second administration of the GHQ-12. And if it persisted over the threshold, they were invited to come to a baseline interview. During the baseline interview, they will be assessed by a person with the Hamilton Depression Rating Scale. And at that point, we would divide the group. I'm actually only talking here about the intervention group. Of course, they were randomly allocated to a control group that just simply received the usual care in primary care for depression, which at that time was very, very, very little. So the group that came into the active, that we call the Improve Care Program, were divided into 2 groups according to their severity at baseline. So those who had more severe symptoms, all of them were invited to attend a group, which I will tell you a little bit more of what it consisted of in a minute. All of them went into a group, but the group that had more severe symptoms would be assessed by a doctor, a general doctor, for the possibility of prescribing medication. I think what it was interesting at that point in time, and perhaps one of the reasons why we were funded by NIMH, it was because we had reversed the order of treatment options. In the US at that time, if you had depression, the first line treatment was medication. And if you didn't respond to medication, then you were referred to a psychotherapy intervention. So we decided to reverse this and give to everybody a psychological intervention at the start. And that was interesting for some of my colleagues in the US because they were doing just the opposite. So once they entered the thing, they would be reassessed 6 weeks later. It's interesting to say that, the reassessment was part of their psychoeducational activities. So it was done in the groups. So, and I'll tell you later, but that provided an opportunity if the person still remained with severe symptoms or had worsened the severity of the symptoms, the person was referred again for a general practitioner re-evaluation. So if the person wasn't on antidepressant at that point, the general practitioner was likely to consider initiating medication, or if it was on medication, there was a possibility of adjusting doses. They received a number of sessions, 9 sessions, and then at the end of the 9th session, they were given on a weekly basis, and then booster group session, 2 booster group sessions after that. So an example, as I said, those just to kind of re-emphasize what was the idea. This is the step care part of the program. Those who had less severe symptoms, just the group intervention and a follow-up, all done by a health worker, not by a doctor. Those with more severe symptoms, they will receive a more intensive intervention, the group intervention, the follow-up between the health worker and the GP, and potentially the prescription of medication. So this is what was the step care of the intervention. As you will see, there was a very intense collaborative fashion in this intervention, in which GPs and health workers were working both very closely on trying to improve the condition of the patients. So the main components, again, re-emphasizing the main component, this is a multi-component intervention. It was a psychoeducation, educational groups for all people entering the trial. For those with more severe condition, medication, and the medication that we had, it was fluoxetine, which was quite new, quite novel at the time. There wasn't fluoxetine in primary care clinics. So it was the beginning of fluoxetine in primary care. These days, they have, other options, not just simply fluoxetine. And finally, general support for all, plus active monitoring done in the group, mostly empowering with the assistance of a care manager for all. And at the end, I will show you a very interesting example of what you can achieve if you really empower people to do things and to look after their own problems. So what was it in the psychoeducational groups? The groups were quite large. Now I realize that. At the time, we didn't have experience with this, so we decided to go for 20 as a number. It's quite a large number for people who don't have experience running group. The groups were run by social workers or nurses. We trained them, but the training was very limited. And they found it quite challenging to run a group with 20 women. Sorry, I made a mistake. It's 7, not 9 sessions and 2 booster sessions. In the groups, we will provide them with information about things that they can do to help themselves. Initially, it was just information about what was going on, which is quite powerful, by the way. When people begin to realize what they have is an illness, it's a very important piece of information that other people have similar kind of things, that they're not going mad or anything like that, that there is treatment for this thing, that there are things that they can do to help themselves. And so we introduced the idea of problem solving and some of the techniques, very basic, of behavioral cognitive techniques. So that was essentially, there was an informative side, and there was a fair amount of discussion of their own problems using their own examples. We had manuals for both, for the social workers and for the patients. We had lots of examples of what you can do, what is the problem, how do you deal with a problem with this idea of problem solving. Quite a few exercises using their own examples. So that was what was happening in the groups. The pharmacotherapy program, it was, as I said, we had fluoxetine, amitriptyline, and imipramine at that time. But as it happened, fluoxetine was the novelty. I mean, it was the flavor of the month. All the women that were, virtually all the women that were prescribed in the in the active arm of the trial received fluoxetine. By the way, you can't see because I've put it white in here, is 20 or more milligrams a day. Interestingly, quite a lot more people in the control group received amitriptyline or imipramine. So the person running the groups will check whether or not the people were, when they had been prescribed, she knew that, whether or not they were taken. At the end of the session, she will ask, for all those of you who are taking medication, stay for a few minutes. I hope you've been able to see my slides. Anyway, I'll go on. So the person leading the group, the facilitator, will check whether or not they were on medication, if they had been able to take the medication, if not, what were the problems, and sometimes will assess them with basic kind of ideas of what to do. If you have side effects, some idea of what, those are side effects, don't worry too much. They're going to be, give yourself a few more weeks and we'll see. If it doesn't improve, I will help you to come back and see the doctor. At that time, we didn't have guidelines for GPs, but we did a very short, brief course of a couple of hours to try to help them understand better how to prescribe medication. Was it a fair comparison? Well, it was really a randomized controlled trial. People were randomly allocated, and the groups were comparable, and you can check those things in the paper. That's the beauty when people publish results, that you can check, whether or not it's reasonable to believe on this piece of information. We have independent blind raters to the point that can be blind because, as you know, it's impossible to blind completely raters. Sooner or later, the patient could make a comment that will reveal what group the person is in. It was excellent. It was an excellent, oops, I've moved back. It was an excellent response rate. We're close to 90% response rate at 6 months. We follow up at 6 months. The assessment were at 3 and 6 months. And we had a very low refusal rate, probably because at that time there was so little on offer in primary care. And here we are. This is the most important piece of information that I have for you, really. If you want to retain one thing, retain this one. So here what you have is a percentage recover. And I want to be clear, I'm talking about recovering, not improvement. Recovery is a lot more difficult than improvement. It means that you no longer have enough symptoms to be classified as a clinical case. And so we measure this thing at 3 and 6 months. And as you can see, this is the usual care. The recovery in the usual care was very low. That has improved a lot with the changes over the last 20 years in the treatment of depression in primary care in Chile. And the 6 months, that group had increased, double actually, which is something that we've seen all over the years, that there is some improvement in usual care group, even if you do very little. Don't ask me why. I personally think there are a number of reasons. There are, monitoring symptoms that you have to do in a trial. Can be therapeutic, and there is also, you have to provide safety nets that can also improve treatment, and so on and so forth. But nothing really impressive. Only 30% of those women at 6 months had improved. What was impressive is what happened with our intervention, that almost 50% of the women at 3 months had improved. A massive difference with what it was usual care at the time. And what it was even more remarkable is that this improvement continued at 6 months. That is something that is uncommon in many of the trials in primary care. When you withdraw the intervention after the research, there is a tendency for this to remain pretty much what it was on your previous measure. And in some cases, even drop a bit. So the results were absolutely stunning. We just couldn't believe it. And a lot of the people who read the paper couldn't believe it either, because they were very skeptical. Every time I presented the result, people would say, well, a lot of placebo effect and this and that. It was difficult for people, especially in rich countries, like the country where I'm working now, to accept that such a brief, simple intervention could achieve such, wonderful result, because, most of our countries are spending so much money into this thing, and, simple thing can achieve a lot. So this is just to show you in a graph, the drop. As you can see, the drop on the red line is the step care improvement program, massive drop in comparison to the usual care. So the next question that the people in decision makers had for us, it was, well, that is wonderful, but, we cannot afford this thing. So this led us to do a cost effectiveness analysis. And essentially, this is what we found. We found that for every additional cost, and I will explain what I mean by this, for every additional cost for every extra depression-free day with improved care will cost them 216 Chilean pesos at the time. So what do I mean by this? This is the cost, for, if you consider that some people were improving with the usual care, If you remove, and that will have a cost. If you remove that and you start now considering over and above those improvements with the usual care, for every extra depression-free day with the new intervention, you will have to, that will cost you some money. So the money that will cost you to give these women one more day free of depression was 216 pesos. Now, at the time, I use the example of a bottle of Coca-Cola, and a bottle of Coca-Cola at the time was costing 350 pesos. So it was like 2/3 of a bottle of Coca-Cola. And Coca-Cola was quite cheap in Chile. And so it wasn't a massive amount of money what it will cost you to give these women, 1 day depression-free. I'm not saying that this made the difference, but I think it probably contributed to show that it was affordable by the country. Soon after this, the country made the decision. I'm not saying that this was the essential bit. There were lots of other things happening in the country, but this was a massive piece of evidence that not many health programs, let alone mental health programs, were able to show to decision makers. So we were able to show them that it was a big problem, that we had a solution, even if we didn't solve poverty in the country, that would give the people, some relief for the symptoms. And it was affordable. The country could do it. So eventually we managed to persuade the government, and the government introduced this as a national program in primary care. And I have to say, probably that was the first national program of depression in primary care throughout the world. No, not many countries, even rich countries, can say that they have done this. It was targeted, of course, it was targeted for depression, but that was our original intention, to start with something and eventually begin to spread it to other conditions. And today, there are at least 10 different programs in mental health in Chile, similar to this one. And it started increasing the number of people that were being treated. In 2018, there were about 500,000 people being treated by the program. If you remember that I said to you there are 19 million people in the country, it's quite a substantial number of people that now can have access to treatment. Yes, in primary care, but that gives the opportunity for the poorer people, which it was our intention, always focalized in those that have the least. This is a graph just to show you how the program was growing until 2008. And this is to finish what I wanted to share with you. These are pictures of women, Chilean women in one of the primary care clinics. The picture on the left-hand side was taken in 2009, I think. And what you see, there are a bunch of women in there. This is a clinic, by the way, it's, in Chile. And they're kind of sort of doing exercises. As you can see, they have uniforms and this and that. Essentially what had happened, it was that many years after we completed the program, I was working on a different program with postnatal depression in Chile. And somehow somebody heard that I was in there, the director of the clinic, and contacted me and said, listen, we're having an event today at the clinic, and we would like to invite you. And so obviously I asked what it was, and she told me that one of the groups that we had been working with decided to continue meeting. And they started doing their own things, looking after each other, and developing activity. So initially they had organized outings. They created a system of buddies that, when a person was depressed, another one would look, kind of keep an eye on that person. Then they started with this thing of keeping fit, and they negotiated with the clinic. And this is a really interesting point, actually, because these empowered women negotiated with the clinic director to get a space in the clinic to do this keep fit thing, so that they will do it in the evening when, the busy clinics were not being run. And in retribution to that, they accepted that if in the clinic, people identify other women with depression, they could be sent to the group and they will be welcome and supported. And the incredible thing, this other picture that you see on the right-hand side are these women last year, still meeting, still running the program. I mean, of course, these are some of the women. There are lots of other women that had been joining the group. But the point that I want to make with this is an intangible benefit. We never thought about this, but the fact that these women were able to get better from their depression, release energy, power, so much so that they were able to begin to regain control of their lives and support each other in this process. So, there may be poverty there, but that doesn't mean that people don't have the capacity to do something for themselves. So with this wonderful thing, which is probably one of the most exciting experiences that I've ever experienced in my career as a researcher, I stop here. Thank you very much for your attention.
Thank you, Professor Araya, for your sharing. This is a really valuable chance to learn more about your intervention developed in primary mental health care and how this benefits people with depression in low and middle income country. So we now open the floor for questions. I see a couple of questions in the chat box that we can start with. So that we got the questions from Gloria. And she's saying, totally agree that rich countries should learn that simple things can do a lot to improve mental health if done properly. I also like your point earlier about the added benefits of helping women, as they can in turn help others they take care of. Did you look at the impact of your work on the hidden cost of unpaid or family care? Women caring for their husband or children or grandchildren in the cost effectiveness argument?
I knew Gloria will ask me something like this. After spending time surrounded by economists. in economics, you have at least two ways of estimating costs, direct cost and indirect cost. When you do direct cost, it's essentially the cost of delivering the treatment. And when you have the opportunity to assess indirect costs, which are cost of transport, arranging care, and a few other things, in this particular case, no, we did not have the opportunity to estimate indirect costs. We did this study with a very small budget. I don't even want to tell you how small it was. So there was a limit in terms of what we could do. And at that point, we decided to prioritize the idea that we had, that we wanted to sell this to the Ministry of Health. So the Ministry of Health would probably be a lot more interested to know, so how much is it going to cost us, rather than what are the benefits or the cost to the people that you are treating. So unfortunately, we did not have that data. I can see that Jess Tan is also asking a couple of questions. May I answer those questions?
Yes, sure. I'm just aware. I'm not sure if the participants can see it, but I'm going to repeat the questions first. So she asked two questions. I think it's probably related to the multi-component and cross-sectoral interventions that you have mentioned. So she's interested in what profession is the care manager and what is in the content of the psychoeducation program.
Yeah, both very important questions. For the first one, the profession of the care managers. The care managers, I would say there weren't too many, but most of them were social workers. In Chile, there has been a tradition ever since we introduced primary care that every primary health care clinic has a social worker. So the social worker is a person who is in contact with the social problems of people. People come to, when they have problem with money or managing things or legal problems, whatever, they come to the social worker. So they have a very special relationship with the social workers in the clinics. So we thought, if the social workers were keen on this, we would be really interested to use the social worker as the person who would be the care manager. So most of them were care managers, but there were two nurses as well. So that's for the first question. We never regretted having chosen the social workers, to be honest. I think that there are great opportunities there to do a lot more. The content of the psychoeducation, I did mention during my presentation a little bit, not a lot. But as I said, the first part, and where we call it education, we were very kind of, just to introduce it. At the time, I was very interested on the work of a woman in the US who was running psychoeducation program. I think her name was Kate Lorich. And she was doing stuff for chronic conditions. And so the first council, thing that it was important, it was information. So we provide a lot of information. We explain, what you are experiencing is not laziness. These are symptoms of an illness. We call it depression. You can call it whatever you want, or you don't need to give it a name. But when you are depressed, you experience these things. And, so that symptoms of an illness, not laziness or not willing to do things, and so on and so forth. So there was a lot of that. And then I said, this illness, can be treated, we can help you and you can help yourself. So if we need to help you, these are the kind of things that we can help you with. And so we talk about therapy, medication, and so on and so forth. And then we explain that they could help themselves. And, most of the sessions were going to be about how they can help themselves. And so, problem solving was a very key thing, sort of trying to help them, because a lot of them had, problems, social problems. So we explained, what we mean by problem solving, that, they need to identify what is it exactly the problem, and if you need to cut it down in smaller bits, and if you do that, choosing one of them and targeting, planning what to do for that one, kind of checking if you made any progress, and so on and so forth, the traditional problem-solving approach. That was very important. We did try to, at that time, we call it cognitive restructuring, which is challenging automatic negative thought. At that time, that was very popular. We did try to introduce this idea, but we found it very difficult. And in the end, all of that, the taking message for most of the women, we did quite a few qualitative studies afterwards, try to understand, what went on. But the take-home message for most of the women of that part of the treatment, it was, I need to be more positive. I need to be careful with my thoughts and try to be more positive, rather than the whole process of, identifying the thoughts, challenging them, trying to replace them with more functional thoughts and so on and so forth. That was never worked really well. And finally, it was quite a bit about supporting each other. The power of social networks, and identifying, kind of sort of helping other people with similar problem. How can that be done? And then, in there, the idea of joining another person in buddies, couples that they will help each other. So if you couldn't come to the meeting, there would be that person that can contact you. All the women live in the same neighborhood, so they could walk around and they, visit each other and so on and so forth. That's essentially the psychoeducational program.
Ricardo, this is Terry. I co-direct the JoyAge program together with Gloria, and Gloria is not in Hong Kong, so she cannot show up here. So I want to personally say thank you for you to, deliver such a wonderful speech, in the symposium. But I do have two questions I want to ask you. The first one is, since your program focus on women, which I think is a very good starting point, particularly interestingly, for microfinance program, as an anti-poverty program, used in a lot of developing countries, they also focus on lending microfinance to women, mainly because women have a, lending money to women as an anti-poverty program has a big positive effect on the family. But if you lend the money to men, they use it, in gambling, in smoking. But having said that, do you think the program will have a comparable effect if it was implemented, with men?
Hi, Terry. Yeah, it's a great question. I've been asked that question 100 times. And I have to tell you that I have tried it. First of all, to say that microfinance idea is something that we've been trying, and it's a fabulous idea. I wish we had this with these women. They did their own microfinancing, which is amazing. They identify where there were opportunities, approached the municipalities, they got the money. We didn't do that, perhaps if we had been more proactive, we could have done that, but nobody's perfect. This is how we started.
Yeah.
But the men, we have tried the men in a couple of places, actually here in the UK, and it was really, really hard. We just couldn't recruit. And I know that there was another person here in Liverpool who was trying that, and he, it was quite interesting because he was more successful recruiting men. And the way he did it, Terry, it was inviting men to the pubs.
Oh.
Because men here in the UK tend to meet in pubs.
Mm-hmm.
Now, I'm not saying that that's a great idea. I mean, you invite them to have a drink.
Yeah.
To the groups, but it was a place where they felt comfortable. They will go there and meet in there. Women felt comfortable going to the clinics and meeting other women in there. They know each other in the neighborhood. They come with their kids for the child development program. So there's more contact. But it didn't work with men for us.
Okay. Another one follow-up is yesterday we have Professor David Clark from Oxford talk about the IAP program in the UK. Yeah. And then in the IAP, they use a paraprofessional instead of social workers. So in Hong Kong, actually, we are struggling between whether we want to train more social workers to deliver this kind of low intensity psychoeducation program, or we train a group of paraprofessionals to do so. So what is your thinking between, for example, if we implement this program using paraprofessional without that required clinical? So what is your take on the differences between paraprofessional like the IAP versus the social worker in the program?
Wonderful question. Thank you for that question, Terry, because I actually work in IAP. My clinical work is with IAP. So I could talk to you for an hour about that. But in IAP, most of the people who are delivering treatment, as you know, in IAP, there are low-intensity workers and high-intensity workers. The low-intensity, which is the great majority of providers, are, recently graduated psychology students. And then the high-intensity are more experienced, psychologists and various other people. I'm not so sure how many paraprofessionals really, and what is included in that description that David may have given yesterday. But in the case of Chile, in Chile, there are lots of psychologists. For some reasons that I don't have the time to explain, but the production of psychologists is massive. So there are lots of unemployed psychologists, and and psychologists actually that has driven down the salaries, the wages of psychologists. So what we did in Chile, it was that we sold to the government the idea that every primary care clinic should have a psychologist. And it did work. So we managed to sell that idea, and until now, it's just become part of, the staff. Every primary care clinic has at least one psychologist. There are some primary care clinics now that have 2 and even 3, the large one, psychologists. So, but with that, there's been more room for the clinics to decide how they want to run these things. So I don't really know what's going on now.
Okay.
I think in some of the clinics, the psychologists are running the groups. In some other clinics, there are still, social workers running groups. It really depends on what the country wants to do, what they feel comfortable with, the resources that may be available.
Okay, thank you.
Okay, so I'm being mindful of time, so I am afraid we might have to stop here, but we welcome more discussion later with Ricardo. So I'm going to pass the stage to Dr. Marcia Scazufca, and right. Okay, so let's see if we can get Marcia here. Yes, Dr. Marcia Scazufca is a visiting researcher at the Centre for Global Mental Health Research Group, King's College London. Her research focuses on psychiatric epidemiology and psychosocial interventions for older adults. So today, Dr. Scazufca will talk about the randomized clinical trials for older adults with depression in socioeconomically deprived areas in Brazil. Marcia, please.
Thank you, Dara. Can you hear me?
Yes, I can hear you.
Yes. So thank you very much, Dara. Nice to see you again. And thank you very much for the invitation to give this talk in Hong Kong. I'm not in Hong Kong, but we are all together in Hong Kong at this moment. So I will share my screen. That is, well, let me try to share my screen. It's here. Okay, can you see my screen?
Yes, I can see a screen.
Yeah. So today I will talk about this task share collaborative care psychosocial intervention for depression among older adults in Brazil. I work at the University of São Paulo, in Brazil. And just my Ricardo Araya, that you just saw him, we work together in this project. And we've been doing it since 2018. Yes. So as Ricardo did, I will tell you a long story on how we developed this project and how we did the clinical trial. And we can chat about it a bit as well, because I think the process is much more interesting than the results. So Before I start, I like just to say that very recently, we were together with people from Hong Kong, with Dara and Frankie, in a symposium in Pittsburgh. It was a symposium about digital psychosocial interventions for older adults in Brazil and Hong Kong. I was sharing the symposium, and Karina, Thiago, and Monica from Brazil were presenting, and Dara and Frankie. I think there has been some collaboration between Brazil and Hong Kong. We've been talking about things, about projects, about ideas. And one of the things, the first thing we really did together was this symposium. And people can ask, why Brazil and Hong Kong? It's a bit far away. It's like, I don't know, 24 hours. I don't know, it's a bit less flying, but it's really far away. It's two completely different countries, realities. But as you will see, there's a lot in common. A lot, no, some things in common. Brazil is a huge country with a population of around 215 million people, and Hong Kong's a bit more than 7 million. I'm not sure if I'm right, but this is what I found. And in Brazil, we say older adults are over 60, and there is around 31 million older adults in Brazil. And in Hong Kong, the population is a bit more than 7 million, and the population above 65 is 1.4 million. When I look at the population of Hong Kong, it's half of the population of São Paulo city. It's very interesting, a bit more than half, okay? It's like a baby for me, but I know it has a very complex reality and a very interesting place. There is this photo of Hong Kong is the photo I see in Brazil. I'm sure there are other places in Hong Kong, but it looks beautiful, very modern. And this photo you saw on the left is the photo of Brazil. São Paulo is where the big buildings are, and this is a motorway that takes you to Guarulhos, where we did our study. On the front of the photo is Guarulhos, behind is São Paulo. I could show you a more interesting photo of São Paulo, but I think it shows you more the reality where we are working. So why Brazil and Hong Kong? When we start talking mostly with Gloria from Hong Kong, and she's been participating in our meetings. We have on Fridays with Ricardo, people in the UK, people in Brazil, people in Ireland, and Gloria started participating in our meetings, and we found out that the older population in Brazil and Hong Kong have a lot in common. They have lower levels of education than the general population, low IT literacy, and also high prevalence of depression. I didn't know that in Hong Kong, the older population had such characteristics. For me, Marcia, Hong Kong, everybody had a very high literacy. They were very high tech. You know, that was very new for me. And as you heard from Ricardo, all these things are very important when we think about how to treat older people or any population, how we can deliver something that they can understand, they can participate, and they can engage. So here is a map of Brazil here on your left. And on your right is Brazil and South America. Brazil is a very big country in South America. It's the wealthiest country in South America. Is the state of São Paulo is the wealthiest state in Brazil, and the city of São Paulo is the wealthiest city in Brazil and in South America. When I look at this map, here is Brazil, and somewhere, can you see where I'm pointing? Yeah, Dara, can you see?
Yes, we can see it. I'm
Yeah.
not sure. Yeah.
Hong Kong is somewhere here.
Yeah.
Yes. So it's a long way, and it's a very complex country. Just to show you, this shows how much we spend with mental health treatments in Brazil, mental health care, and another Latin American countries. So we don't spend much. We spend around 2% of our budget. You can see that other countries that are very, very poor, like El Salvador or Honduras, spend more or less the same. So Brazil has a lot of problems and is not spending much money with mental health as well. So this is the map of the São Paulo city, and this is another very, I would say, sad indicator about the mean. It's a map of inequalities in São Paulo from 2019, and the mean age of death. You know, we're talking about the wealthiest city in South America, okay? The difference in mean age people die in the most wealthy part of the city and in the poorest part in the city, there is a difference of 20 years. That's a lot. And as you can see, this is the center of the city, and only in the center of the people, here people live longer. And as you go to the peripheral areas, it's easier, people die earlier. I think this indicator, the death, it's a very important one, because if people die earlier, it means their health is not great. And most of the population live in the peripheral areas. And we can also think depression is biggest problem in these areas. Of course, it's in the central area as well, but people die for several reasons, and we have more depression in these peripheral areas. This inequality is not in São Paulo. It's the wealthiest city. We should have much less inequalities. Is it all around the country? And we have states in Brazil that are very poor, that others are better, but the inequality is everywhere in Brazil. So we need to think about ways to deliver care to this population, to make it more unequal. One thing that Brazil did a few years back, Brazil has a universal health system. Like, it's free, everybody can use it, and the main part of the system is the primary care. Then we have secondary care, then so on. And we have this universal health system since the Constitution of 1988. We had a new constitution, and there were a few things before, but then the Constitution said Brazil from now has a universal health system. It's all over the country. It covers all the population, more than 200 million people. And it's free. People just can go anywhere you go in the country. The health system is there, and it was built on the same basis. So the health system the structure is the same all over Brazil. We have two types of primary care in Brazil: the traditional model and the new model, that is the family strategy model. The big difference between the traditional model, the new model, is that both are based on catchment areas. Like, the clinic covers a catchment area. But in the new model, the people that work in the clinic, they register everybody in catchment area is registered with the clinic. So actively, they go to their house and ask if they want to be registered. And in the old model, if I live in a catchment area with a clinic that's primary care clinic in the old model, I can go to the clinic. I can register myself, but the clinic doesn't know who lives in the area because it's only people that go there that will be registered. It makes a big difference for the health system because in the new model, we can plan things for the whole catchment area. We know who lives there. We know their problems. We know many things. This new model covers around 65% of the population, of the Brazilian population. And this new model is based mostly in the most poor areas of the country. So this is where they start building the new model of primary care clinic, the primary care in Brazil. The clinic, it looks like the same, there is no difference, but what's inside the clinic that's different? In the new model, we have the family health teams, and each team has a minimum of one family physician, one nurse assistant, and around 6 community health workers. And they provide care to up to 3,500 people that live in the catchment area. Of course, it varies a bit depending on the area, but in most family health clinics, we have these teams and they look after these catchment areas. In the traditional model, we have like a physician, we have some specialists, we have like pediatricians, sometimes gynecologists, we have nurse, we have assistant nurse, and we don't have community health workers. So the new model is based on this family health teams and the family physician, the nurse, and so on. Here is a photo of a community health worker working with a woman, and this is a nurse assistant in the house of a man. They worked in our project, but this is what they usually do. Of course, they didn't see people with depression, but they visit these families once per month. The idea is that once per month, all families, all households will be visited by a community health worker in the new model. So, who are the community health workers? They're very important for us in our project because they will deliver the program we developed. The community health workers are non-health professionals that live in the community, they work, and they visit households regularly to identify health problems and monitor ongoing treatments. They can be men, women, and they need to have at least 11 years of education to work in this job. When they enter the job, they don't have any training in health. They are not nurses, they are people that live in the community and have the skills to be trained to do the job. So what we know about how to treat depression in the community for large populations, we have a big problem in Brazil and everywhere. The prevalence of depression is very high. We know that people are not treated, people are not identified. People, the integration between mental health and primary care in Brazil is very poor. We have, I think, most problems people have, but we have a huge population. And the primary care physicians are still, they don't want to treat people with mental health problems. And when they treat, what they do is medication, And, the person goes back to the doctor and the doctor doesn't do the assessment again. It's a bit of a problem because they treat them, but depends a lot on how the physician, if the physician likes to see people with mental health problems, it's better. If the physician doesn't like it, he won't identify, he won't treat. So we know that in primary care, collaborative care programs, they work for depression among older people, and they are effective in primary care. We know that in these collaborative care programs, if several professionals collaborate with the same treatment plan, it will work. And also, we know that when we have no mental health specialists involved in these programs, we can deliver it to a large population. In Brazil, as in many other countries, there aren't enough mental health specialists to treat this huge people of people with depression from all ages, it's not older people. So we need help from others people to try to treat all this population. And there were, when we started the proactive study, there were only a few studies with elderly people in the world that used collaborative care. The main two studies until now are the IMPACT in the United States and the Castle Plus trial in the UK. And collaborative care depends a lot on the context you're using it. If you look at these two studies, what they call non-mental health specialists is very different from what we call non-mental health specialists in Brazil. There are no mental health specialists, maybe it's a social worker. And for us, we've been developing this project with community health workers. They're completely different. Their work is completely different. Their training is completely different. So when you develop collaborative care programs, you need to make it work in your context and with the population you see, and with the sort of professionals you have. I can't do something maybe you do in Hong Kong or they do in the UK. It won't work in Brazil. You need to adapt it to your context. But so we know we have ideas. There's several collaborative care programs for depression with adults. They're much more than with older adults, but no, not in Brazil. So we don't know whether the collaborative care model, these models are effective for older people with depression in Brazil in primary care. So we had to develop this program from the beginning. When we started working together, myself, Ricardo, and a group of people, we start really from the beginning. We start thinking, what are the barriers to care in Brazil for this older population that live in deprived areas? What are the intervention strategies that we can use to solve the problems, and what would be the likely result? We really started from the beginning discussing it, and so this is how we built the program. So one of the main barriers is neglect of care for older people with depression. As I said, most of them are not treated, are not identified. No one, it's a person that has a problem, but no one identifies it. So case identification is needed. We can't develop a program if we don't develop the case identification strategy. So, and we think that if we develop the case identification and the planned intervention for this population, probably it will be a cost-effective solution. and it may reduce inequity in health. So this was the main thing. There was, these people are not being treated. We need to develop a program, and it may be a cost-effective solution. In Brazil, all this, in this new model, in the family health strategy model, the family team, they meet every week to discuss cases. So they already have this work that they meet, they discuss. It's not new for them, telling them, you can collaborate and treat these people with depression, deliver more for them. But if they don't identify people with depression, if they don't treat them, they won't collaborate in this case. So there is a very poor coordination for people with mental health problems. They don't like to discuss it. So we had to develop something that would help them to collaborate and discuss this case. And then they would provide best possible care for these people, and they would receive more attention. The other thing in Brazil, the health system doesn't use much technology. Now it's starting more and more and more, but it was very poor. So the health workers would go to people's house every month. They stay in the streets most of the day with a pen and a notebook. Then what you do with all this information, it's very difficult to keep this information. So now they're starting using tablets, but when we started, there was no technology. So we also decided that we would develop the program that would identify case, that will have a planned intervention, that was collaborative care, stepped care, and we would use technology to help the program. So we developed an app that was used in tablets during the health workers' visits and supervision. And also we thought that we had to train these people, these community health workers, but we also need to support them because, they don't have they didn't go to university, they didn't have any training in mental health. So the app was a way to give them support. They could share the information, they could take the app to the clinical supervisions and show what was happening. And they also could used the app when they visit the people, during the clinical supervisions, and also during the weekly meeting they have with other people in the team. So, as I said, we have few mental health specialists in Brazil. So we decided to use task sharing. So we trained community health workers and to be the main person in our intervention. So we gave them a 3 days training and weekly supervision and the support of this app that I will show you soon. And we thought that with these strategies, we use the existing resource we have in Brazil to implement a cost-effective intervention. So, as I said, in each context, you have to develop the collaborative care intervention with your own resource. That we know in Brazil it was not being used properly. These people, these community health workers could do a lot, but they were not involved in the treatment of depression or other disease. We also, as we were working with other people, and many other people have mobility problems or other health problems, we decided to develop an intervention that was home-based. What we see in Brazil, maybe in other places as well, is people that have more resources, that in reality have less health problems, are the ones that get more care. Because you need to go to the clinic, you need to wait. You know, you need to have a lot of energy to go through all this process. And we decided to develop a program that could look after the more disabled people as well, not only the people that had more, could go to clinics and could wait and could shout, because in Brazil we say, if you shout a lot, you get what you need. No, we didn't want to do it. We wanted the opposite. We want to offer this program for everybody. And so we would be sure that people that need more, we would also get it. So we developed this program as a home-based intervention, and we were able to look after disabled older people, and also we hoped to improve adherence to the treatment. And the other thing in Brazil is that in mental health, you know, people don't discuss if treatments need to be based on scientific evidence. I'm talking about psychosocial treatments, psychological treatments. We have this tradition of individual psychotherapy. We come from a very tradition from psychoanalysis, and now there is a lot of cognitive behavior therapy. But this idea that we need to do something that's evidence-based, it is not there for mental health. Because one thing is, when I do cognitive behavior therapy in my private practice, I don't have a private practice, but people do. And, you know, the model is ready and there is evidence that it works. But when you go and see this population, I'm not sure if it would work, you know. I think we would need go through a lot of adaptations in this same model to work with this older population. So we decided to develop this program using the forms of treatment that there is evidence that they work, like psychoeducation, behavior activation. A lot we also talk about relapse prevention and assessment-based care. So we use techniques that we know it works, but we didn't know if it would work in a program with other people, that the main person that delivers this program is our community health workers. So we needed evidence. So one of the results we wanted when we developed this program was to see if we could have evidence and say it works. So the proactive program aims to, after all this time we discussed this thing, we developed the program, we had in mind that we wanted to provide care to older people with depression living under the privileged areas registered with family health clinics in Guarulhos. And we wanted the program to be aligned with the target population needs. It's a population with low levels of education, eye and hearing problems, and mobility problems. And as I said in the beginning, the family health strategy is similar all over Brazil. So we thought if we develop this program, maybe in most family health clinics, they can use it. But we started with a pilot study that had the aim to assess the acceptability and feasibility of the proactive program. Then we didn't have any idea if people would accept it and it would be feasible. Then do the clinical trial to test the effectiveness of this program. So the proactive program principles are task sharing. So non-health professionals play the main role. They deliver the home-based intervention. It's a stepped care. Some people receive 8 sessions, and other people receive 11 sessions, based on the level of depressive symptomatology on the second and third sessions. And it's also a stepped care because we think this is the first step. Maybe this is the first step to start the treatment for depression. Of course, many people wouldn't be okay at the end of the program, or during the program, they would need something more. So they would see the family physician, then they would see the specialist. So it's step care in all sense. We think this very large program with probably cheap and effective program could treat a lot of people, and less people would need to go to other steps. And so more people would get treatment. You know, if you need more, you get more. And people that need less get less. At the moment, we don't have this stepped care model. What happens is that people that have more access will get more. It's unequal there. The access to services is unequal in a way. So a collaborative care model, and all members of the family health team discuss the case, but the health worker is playing the main role. And also we developed this application to give support to the community health workers. So the proactive program is a 17-week program for older adults. The sessions are delivered at home, and we use behavior activation and psychoeducational approaches. Just to give an idea, in the first 3 sessions, they receive mostly ideas how to cope with the problems of depression, psychoeducation, and these first 3 sessions are one session per week. And on the second and third session, the health worker assess the depression level with the PHQ-9, and depending on the level of depressive symptoms, they will go to the low or high intensity regime. And this second phase takes 14 weeks. In the low intensity, they have 3 biweekly sessions and then 2 monthly sessions. And in the high intensity regime, they receive first 6 weekly sessions and then 2 monthly sessions. So, as I said, we use psychoeducation, coping strategies, behavior adaptation, and measurement-based care. So, before we started the pilot study, I won't make much difference between the pilot study and the main trial, because we developed the whole program before the pilot study. The pilot study, when we did the pilot study, we did the full study with a small group of people. And we after the pilot study, we made only a few changes in the program, but not major changes. So when I talk about the pilot study, I'm also talking about the program we delivered in the clinical trial. So, but we had to develop the app. That was something important. This app was going to facilitate decision making, improve collaborative care. We thought the app would improve quality of care and would improve adherence to the program. And the main thing was to give support to the home psychosocial intervention that was delivered by the community health workers. The app I will show you is very structured and simple. And in the app, you can monitor mood, suicide risk, activity levels, and other comorbidities. Here is how the app starts. This is the proactive app. The community health workers insert the name and the password and enters the app. When I will say she, because most of them are women, okay? When she enters the app, she gets a list of names that she's seeing in the proactive program. In the trial, they were only seeing 3 people. So, and there is things about that each patient here. Then when they started the program, how many meetings they had already, and when was the first, when the last, when will be the next, and the PHQ-9 scores over the sessions. So now I will show you the first video of this program. Is how they, what will show you. It's how the health workers introduce the program to the patients, if I can, because I need to stop. Oh, I will stop sharing my screen, and Dara and her colleagues will present the first video. In this first video, the video is installed in this app, is part of this app. And so the health worker starts the session, start chatting with the person. It's like a book. You do like this with the book. And then they watch a video together. So this is the first video.
Seja muito bem-vindo ao nosso atendimento. Eu vou ser sua apresentadora e acompanhar você durante todos os seus encontros. Eu quero mostrar algumas das ferramentas que a gente vai usar para ajudar você a se sentir melhor. Uma delas é esse tablet. Nele, o profissional de saúde que está com você vai encontrar tudo o que vocês precisam saber para o seu atendimento ser um sucesso. Uma das ferramentas que vocês vão usar são vídeos como esse, onde eu vou trazer informações úteis sobre o seu atendimento. Para isso, a gente vai ouvir algumas histórias, com a ajuda de 3 personagens que são muito parecidos com pessoas que você conhece. Eles são o Sum, o Nê e a Sani. O Nê e o Sum, assim como você, estão se sentindo tristes e para baixo. A vida dos dois não está fácil, mas vai melhorar se eles fizerem o atendimento direitinho, ajudados pela Sani. Toda vez que a Sani visitar o Ney e o Sum, ela vai usar o tablet para fazer atividades, anotar informações. Nosso atendimento vai durar mais ou menos 5 meses e os 3 primeiros encontros vão ser semanais. Então, vamos continuar? O seu caminho para se sentir melhor começa hoje, tá bom? Daqui a pouco a gente se vê de novo. Tchau!
So just a minute. Can you see my screen?
Yes, we can.
Okay. So when the health worker, she used the tablet as a book, and she starts the session. And our idea was like, these people, they received 3 days training from us. And when they go to their house, they have the support of this tablet. They always use the tablet before they start any conversation. So They go to their house, oh, hello, how are you, blah, 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 blah. So I would like to show you a video, and the video explains the treatment. And then the idea is, at the end of each video, they say, oh, now let's chat about it. So the person can ask questions, can make comments, and the session goes like this. Then they start chatting, and they will see another video, and they will chat about the video. So the videos help a lot. They give a structure to what all community health workers will show to patients and what they will talk about. So I said that one of the principles of this intervention is that is a measuring-based care. So in all sessions, we measure depression using the tablet. This is one question from the PHQ-2. So they, together, the health worker and the person, the health worker reads the question and asks the answer. And we always, when they, before asking the questions about depression, there is a video that explains how the person should answer the questions. Like in the first session, this video has about 2 minutes, and then in all other sessions is about 15 seconds. Oh, now we're going to answer the questions. Remember, you can answer whatever you want. So there is always an explanation. And now, this video, it's in the first, second, third sessions, we give a lot of information, psychoeducation for patients. And in the second and third sessions, we talk a lot about simple ways of dealing with the problems of depression. What we do in the first session, in the second and third session, they start the session, and one of the first things is measuring the symptoms. So this person here said, I have sleeping problems. They could say, I have sleeping problems, and I don't have any interest in doing things. And the community health worker will ask, which problem do you want to discuss today from the problems they marked? So the person says, I'd like to discuss the health problems. So the tablet will help them to discuss these problems. I will show you the video that explains what I'm saying. They will show the video, not me, sorry. Can you show the video, please? I think I need to stop sharing my screen or not.
Vamos falar agora de uma ferramenta que vai ser muito útil para você sair dessa tristeza. Essa ferramenta é chamada Roda da Piora e da Melhora. Ela ajuda você a entender como o que você faz pode piorar ou melhorar o jeito que você está se sentindo. Para falar dessa ferramenta, vamos começar com o exemplo do Ney. Quando o Ney está com depressão, ele se sente desanimado demais para fazer uma coisa que gosta muito, como passear pelo bairro. Se ele não faz nada para se sentir melhor, ele se sente ainda pior, mais desanimado e mais triste. E a depressão piora. Assim, você pode ver que se a pessoa que tem depressão não faz nada para se sentir melhor, ela acaba ficando mais triste e desanimada. Mas não se preocupe, a roda gira para os dois lados. Quando gira no sentido oposto, ela se transforma na roda da melhora. Vamos ver? Quando o Sun está com depressão, ele fica triste e não tem vontade de ligar para os amigos. Mas aí ele pensa, o que é que eu posso fazer para me sentir melhor? E aí ele decide que ele pode ligar para pelo menos um amigo. E isso faz ele se sentir muito melhor. E a tristeza e o desânimo diminuem.
So, can you hear me, Dara?
Yes, we can hear you.
Yes. So what happens? The session starts, the second and third session starts. The person, they do the PHQ-9, they have a chat, how was the week, and all these things. In the first session, the videos are about psychoeducation, what are the main problems of depression. And on the second, third sessions, they will discuss one problem, one of the PHQ-9 symptoms they choose. And we have different videos for each problem. So if the person says, I would like to discuss my problems, sleeping problems, they will go and the tablet will show the sleeping problems video. Or I'm agitated, the person just wants to discuss that he's feeling agitated. So there will be a video about it. So we developed nine videos, one for each symptom. And this was very good because we had 2 sessions and sometimes they wanted to discuss more problems. So, and after they see the video, they start discussing with the patient what to do. Simple ways to cope with the problems of depression. So if I say I have sleeping problems here, it's in Portuguese, sorry. This is, so if I've chosen to
Marcia,
discuss
we can't see your screen. You have to share your screen.
Ah, no, sorry.
It's okay.
I didn't know. So can you see now?
Yes, thank you.
So I will improve it. So if the person has chosen the sleeping problem, the person sees they discuss, they see the video, and then they learn how to use simple strategies to cope with the problems that they saw in the videos. The same thing they will do here together with the community health worker. So the sleeping problems here, it fills in the app, transfer this information to here. So I have a problem like I can't sleep very well. And then the community health worker says, if you don't do anything, what will happen to you? I probably will feel lower, with my mood will go down, I will be sad, and the depression gets worse. So they fill in it together. This is the vicious circle. And then they do the other exercise. If I have a problem, like I can't sleep well, and the person say, what do you think you can do to feel better? Like what Ne or Sun in the animation they did. Oh, I try to relax. What is likely to happen? I will feel better. And then probably my low mood will improve. So it starts like here and the thing starts going round. So this is what happens in the first, second, third session of treatment. And then from the fourth session, some people will receive 5 more sessions and other people will receive 8 more sessions. And this is when the behavior activation will start. And we have several videos. We introduce it in different sessions. We start with easy problems, pleasant activities I can do, then that I did in the last month, but I can do more, then what I can do, pleasant activities I haven't been doing that I want to do again, and then other problems that things I need to change to improve my life. And in the last session, we have the relapse prevention session. And can you show the third video, please?
As atividades que você vai começar a fazer são muito importantes para você se sentir melhor e melhorar da depressão. Se você começar a fazer um pouquinho de uma atividade que você gosta, você pode se sentir melhor e com mais disposição. E com essa melhora, vem mais energia. Com mais energia, vem a vontade de fazer. Quando você perceber, pronto, já caiu dentro da roda da melhora. No começo, é importante escolher uma atividade que você gosta de fazer. Começar devagar e escolher uma coisa que você consiga fazer do começo ao fim é um jeito de garantir que você não vai ficar cansado nem desistir. E é o suficiente para fazer você se sentir melhor. A missão de hoje é um desafio. O desafio que a gente vai fazer é um desafio gostoso. Uma das coisas que o Ney está pensando em fazer, por exemplo, é um trabalho voluntário. É uma coisa que ele sempre quis fazer. Sabe que vai gostar, mas nunca fez. Uma coisa que o Ney gostava de fazer, mas tinha parado, é cuidar das plantas. Então, ele também resolveu retomar essa atividade. A gente vai falar de comportamentos que as pessoas podem ter no dia a dia e que podem acabar se tornando um problema para elas. Um exemplo de comportamento que pode estar te atrapalhando porque você faz muito é ficar assistindo TV o dia inteiro. É o que o Sum está fazendo. E por isso ele está deixando de fazer uma atividade importante, ir numa consulta médica no posto de saúde.
Dara, I think I need to finish my presentation. I think I'm late, isn't it?
Yeah, we still have 3 minutes, and Gloria got a question for you, and you can share some of the parts that you think is important, or you'd like to end here.
Okay.
Yeah.
I will just, this is a thought of community health worker delivering the intervention. And what was important about the pilot study is that it showed to be feasible, was possible to follow up participants, and the results were in the expected direction. And it was also acceptable. The task shifting was accepted by participants and the use of technology as well. And then we started the cluster randomized control trial. We aimed to assess the effectiveness of the proactive program. And we started the trial in 2019, and we had the aim to include 1,440 participants in 20 primary care clinics in Guarulhos. And
Marcia,
yes?
would you like to share your screen again?
Oh, sorry. I thought I was sharing. Oh.
No worries.
Wow.
You were very clear that we got the key messages.
So the, oh, sorry. So we aimed to include 1,440 participants, but as it happened everywhere, COVID started in 2020, and we had to stop the program completely in a week. There was no more proactive. So in the end, we included 715 participants, 355 in the control arm and 260 in the intervention arm. And I think you want to know the results, of course. Our primary secondary outcomes were measured at 8 and 12 months follow-up, and our outcome, the primary outcome, was recovered from depression. So at 8 months was when we measured the primary outcome. In the intervention arm, 8 months after inclusion, 62% of people didn't have depression, and in the control group, 44%. Was a big difference and was highly significant, and it was a very interesting result. And at 12 months, they continue, this difference continued, and it was also effective at 12 months. So the intervention took 5 months. The first outcome measure was at 8 months, and the second at 12 months. Was highly effective. The trial has been affected by COVID. So, but even with these small numbers, it was possible to analyze the data. We just published the main results of the trial. You can look at the more numbers if you want. We also, what is this? So the trial was effective, and now we analyze the cost effectiveness of the trial, and we aim to do more research focusing on understanding how to scale up this program. There's a series of publications from the trial, and our team has people from São Paulo, myself, Karina, and Maria Clara and Ana were working during the pilot, Mayara, and from the King's College, Ricardo, Nadine, and Daryl. And from Bristol, we have Tim Peters and William, and from Limerick, we have Pep. Our fundings are from Brazil, from FAPESP, and from the Medical Research Council here in the UK. And we had support from the Family Health Strategy, where in São Paulo, where we did the pilot study, and from the Health Secretariat in Guarulhos, where we did the trial. So I think this is what I had to present. There is one last video that's 2 seconds, if you can present. And
Sure.
if you go to this YouTube connection here, there is a documentary about the trial with translation to English, and you can see much more about the trial in this YouTube address link. So the last session of the trial, this is how we finished the trial ends. And I think that's it. This is what I had to present. Sorry, I was a bit late.
No worries. Thank you, Marcia, so much for your sharing and taking us through actually the intervention. We are slightly behind the schedule, but I got the question from Gloria. I think we can accommodate one question. So she likes the videos and cartoons. They are very lovely and carefully designed, that make all the difference. And she said, I'd love to respond particularly to the idea of home care for those who have disability for equity. When we first developed JoyAge, we tested it in a subgroup of frail older people who cannot go to centers. The challenge was that once the program ends, they return to a socially isolated state due to mobility problems. So I wonder if you have any ideas for us to solve that problem.
Yeah. What happened in our trial? That's a good question. As the community health worker was doing the intervention, and they visit these people every month already. So they were doing the intervention with the same people they look after monthly, or they go to their house. So the program created very strong links between the community health worker and their clients. stronger than before. So the program for these people was just the beginning. You know, they knew the health worker, but with the program, they were much closer to the clinic, to the health worker. So the health worker, even with the end of the program, would continue helping these people for them to do activities, to be less isolated. I think this, I don't know if I answered the question.
Yes, I think you did, Marcia. Hi, Marcia. I'm Terry Lam. Hi, I co-direct the JoyAge project together with Gloria. But Gloria is not in Hong Kong, so she cannot be here, show up her face. But I just want to say thank you on behalf of the JoyAge team, for your amazing presentation. If we have more time, I would love to ask questions. Particularly, I'm amazed by how you use technology to enhance the accessibility of psychotherapy or for the deprived people in your country. So hopefully I will be able to visit you somewhere in Brazil or in UK in the coming future. But once again, on behalf of the project team, I really want to say thank you so much for your presentation.
Thank you for your invitation. Thank you very much. So have a lovely evening. We're starting the day here. Bye.
Thank you, everyone. So thank you, Marcia, and thank you, Terry, for the last speech. And also thank you, everyone, for your ideas and questions. And this is the end of the today's session. Thank you again for joining us today.